All right. Hello and welcome to the NIOSH Total Worker Health webinar series. My name is Emily Novicki and I'll be your moderator today. I work in the NIOSH Office of Communication and Research to Practice. Today's presentation is using participatory strategies in healthcare to improve support staff and security worker well-being. We're pleased to offer free continuing education credits through CDC's training and continuing education online system. There are many types of continuing education available that you can see on the screen. Detailed instructions on accessing the Training and Education Office site are available for download at the website at the top of your screen. So that's tceols.cdc.gov. Please note that the bright blue activity number is only valid for those watching the live webinar. You will need the course access code to receive credit, and the access code today is the word participatory. The gray activity number is to be used only by those who view the webinar recording or attempt to access CEUs after September 24th, 2023. We're recording today's webinar and plan to post on the Total Worker Health webinar page as soon as possible for those who couldn't join us today. Today's featured presenter is Dr. Jonathan DePierro. Dr. DePierro is an associate professor of psychiatry and associate director at the Center for Stress, Resilience, and Personal Growth at the Icahn School of Medicine at Mount Sinai. He is also on the faculty of Mount Sinai's Depression and Anxiety Center for Discovery and Treatment. His research focuses on the measurement and enhancement of psychological resilience, novel digital therapeutics for PTSD, and barriers to mental health care in disaster responders and healthcare workers. His work is supported by federal grants from the NIH National Center for Advancing Translational Science and HRSA, the Health Resources and Services Administration. He has published multiple peer-reviewed articles and book chapters on stress, resilience, and post-traumatic mental health symptoms. With doctors Dennis Charney and Stephen Southwick, he recently completed a public-facing book on the science and practice of resilience, the third edition of Resilience, the Science of Mastering Life's Greatest Challenges from Cambridge University Press. Just as a reminder, or in case you're new to Total Worker Health, Total Worker Health is defined as policies, programs, and practices that integrate protection from work-related safety and health hazards with promotion of injury and illness prevention efforts to advance worker well-being. It's a strategy approach about integrating protection and prevention. It combines the mandate of safety and health protection with the opportunity of advancing worker well-being. And with that, I'll turn it over to our presenter. Whenever you're ready, Dr. DePierro.
Hi, everyone. I'm excited to speak to you all today about some of the work that we've been doing at Mount Sinai over the past 3 years, and also having its roots in decades of work prior to that. So just by way of disclosure, I receive royalties from Cambridge University Press and from Springer Press. I'm also named on a patent application for a resilience building app that I will only briefly mention later that has not been licensed or subject to FDA approval as of yet. So when I talk about resilience and some of the interventions that we've been doing at our health system, I want to think about it from a few different directions. I'm going to think about and talk about resilience from our experience with the World Trade Center Health Program, which NIOSH supports, where World Trade Center responders, survivors have been followed for 20 years, and Mount Sinai is very lucky to have a longstanding program. We've learned a lot about the resilience of folks. Even those who develop PTSD have a lot of strengths. Social support, commitment to their job, their identity, their meaning and purpose that have driven them through and bring them into treatment and help them recover from the things that they experience. A lot of the things that we'll be talking about today were developments in reaction also to the COVID-19 pandemic. This is the lobby of Mount Sinai Hospital, converted into essentially a field hospital. Thankfully, did not have to be used, but we learned a lot actually through empirical research that we did about resilience with our own healthcare workers in those first waves. We've also, over the years, interviewed special forces instructors, Vietnam War POWs, physicians, other healthcare workers who face personal medical challenges. And the other thing I want to point folks to, actually, this is a lovely article in, I believe, 2014 in the European Journal of Psychotraumatology, talking about the different ways that people define resilience. And there's a lot of debate about what resilience is. There's a lot of making fun of it on social media. But let me just give you this definition of resilience to start. We think about resilience as one's ability to recover, grow, and adapt from challenges big and small. In that, growth, recovery, and adaptation can take minutes, days, weeks, months, decades. In the case, for example, of our World Trade Center responders who struggle with PTSD, that recovery process is taking a while. That's okay, that there is resilience in those processes. Okay, so let me just set the stage a little bit. So there was some early work done. Our colleagues at Mount Sinai surveying our frontline healthcare workers. There's been about, I would say, 20 publications from this data set, longitudinal data set. And what they found is a very large number, significantly large number of frontline healthcare workers answered the survey at Mount Sinai Hospital. Yet, during April 2020, they found that almost 40% of these frontline healthcare workers taking care of patients with COVID screened in for probable depression, anxiety, or PTSD. So that's a pretty high number. And it really showed the acute distress that was going on at that point. Those numbers have changed somewhat over time, but there is, and I'll show you later, some evidence to suggest there is a strong backdrop of distress, not necessarily related to the acute phases of the pandemic, more related to new challenges faced by the healthcare system now. I'll point out a couple of things though. One is this: in April 2020, when we did the survey, what came out of it too is understanding risk and protective factors. So one risk factor is pre-pandemic burnout, which increased the risk of screening in. And one protective factor is being valued and supported at work. So in a few minutes, when I talk about community-based research and community-based approaches, this is the community in which workers live. We're not talking about the individual employee in isolation. We're talking about the employee in context of a department, of a hospital, and who has an employee who might have leaders who may or may not know about things like psychological safety or psychological first aid. So providing leadership resources from these data has become quite important. Just a brief introduction also to what we did acutely during the pandemic prior to the formation of our special center. There was a very large-scale acute mental health response in the Department of Psychiatry, where clinicians were available 24/7 to provide emotional support in those first few months of the pandemic. It was voluntary. There were also unit visits for huddles around mental health support and virtual visits. It was a fair amount of contact, but what we actually know is that some of these virtual visits were not at all attended. Some staff really didn't want to talk or didn't have the time. And there weren't a lot of psychotherapy referrals that people made during this time. That was not the time, that was not the focus. People were working on saving patients, maybe were not feeling ready to stop, reflect, and pause about how they might be feeling. The other thing I'll mention here is that some of these mental health supports were very well staffed in terms of psychiatrists and social workers from our psychiatry department, but the staff on the units that they were supporting might not have known them very well. And so what I'll show at the very end of our talk is parallel efforts done by our Center for Spirituality and Health, our chaplains. And what that will show is that the chaplains who knew the staff, who had been embedded in these units, actually were quite busy and were a go-to source of staff support versus the people that said psychiatry on their name badge. Okay, so based in our experience with the World Trade Center program, where I worked for several years at Mount Sinai and also at NYU, we started the Center for Stress Resilience and Personal Growth at Mount Sinai we started planning in April 2020, just as those survey data were coming in. And the goal of the center still is to support the behavioral health and resilience of everyone who wears a Mount Sinai badge and their adult dependents. So we're really one of the go-to resources for this work, the 45,000 people that work at Sinai. And I'll show you that there's a very diverse range of folks that work in a health system. Sometimes we think only of the nurses, doctors, PAs, and NPs, but there's back-end office staff, there's admin, research support staff, accountants, security staff, housekeeping, kitchen workers. All of these folks make up a health system and need to be considered when we're thinking about efforts supporting a health system. It can't just be about doctors and nurses. You know, the parallel to 9/11, where just as NIOSH showed very robustly with the funding and supports and programs, it wasn't just about the firefighters and construction work, firefighters and police, but it was about construction workers and cleanup workers as well, who were not the traditional face of emergency response. So I'm going to really emphasize that work for everyone robustly, and that I'll show that everyone has, all of these different groups have unique needs. Briefly, our center does education, workshops. We have an app. We do a lot of outreach, and we provide clinical care. I'm just going to allude to the clinical care at the end. Okay, so our work, you know, Mount Sinai has particular expertise in community-based participatory research, really engaging the community, and their work prior to our center was largely communities outside the hospital, communities in Harlem, Brooklyn, the Bronx, especially around cancer care, and addressing mistrust around the medical system. But we leaned on a lot of these principles in starting our center. So obviously, there's a lot of context factors involved. There's the context of a unit. There's the particular slice in time when we started, when COVID case counts were very high. People were losing family members and losing patients. There were capacity issues. So like we had to start the center from scratch and supplement through emotional supports that were available to staff. And our employees and the communities that we serve were largely communities of color that we really needed to consider norms, beliefs, and values in building these programs. And what we continue to do as we evolve is whenever we start a new initiative, and this is particularly true of the project we have funded by HRSA, we always evaluate the readiness of a unit for our intervention. I can maybe talk about that later. And there are relationship dynamics. There's hierarchies within a health system that on a given unit are more enforced or less enforced or more fluid. The hospitals exist as part of a greater health system. So there are structural factors and structural dynamics that we need to consider alongside the individual dynamics that I'm so familiar dealing with as a clinical psychologist. So I've become, in some ways, the de facto organizational psychologist, although I don't often use that label per se. And so our interventions need to be quite tailored. And the idea is that through engaging all these different processes, the outcomes will feed back and change the context. That is to say, if we are successful, we will have sustained interventions that are just not like a one and done type of thing, but interventions along with our institutional partners that will change policies and practices such that the workplace environment shifts even just a little bit into the green for the better. So one of the ways that we did this, as an example, is to have an accelerator in our center. And an accelerator, you could think about it as a way of engaging stakeholders at different levels. So you have an idea, you have a question, you bring this to this group of experts and stakeholders at a variety of different levels, and the output is meant to be multidisciplinary. It's meant to speak to the lived experience of the individuals that you're meant to serve, and it's actually supposed to create new ideas, and in fact it did, new processes, by engaging a constellation of folks. And this is an iterative process. So we actually did this for 2 years, the first 2 years of our center, and we had lots of stakeholders involved, and we discussed things like, how do we measure your services? And it turns out we learned a lot about who has access to email in a health system, who's checking their email, and maybe we need to go to talk at people's huddles, and that became a cornerstone of a project we got funded to actually go to operational huddles. It informed service needs and development, and encouraged, particularly because support staff was represented in this accelerator, it really encouraged our focus on support staff and the understanding that they need their own particular approach. So I'm talking about environmental services. In some ways, security officers can be considered support staff. I'm talking about food services as well. And another goal of this accelerator is to destigmatize seeking behavioral health support, which is a whole nother talk I can give about stigma in mental health in healthcare workers. Okay, let me just briefly tell you about our resilience training and how we shifted this a little bit based on feedback. So there's a long history of work around resilience, broadly speaking, at Mount Sinai. And as the pandemic hit, we took the 10 factors outlined by Southwick and Charney in their writings and turned it into a workshop series where we were offering a series of 11 workshops, about 30 to 45 minutes each, talking about things like optimism, facing fears, social support, meaning and purpose. And that was geared in part toward dealing with COVID at that time. And what we found and why we had to retool is that, and we also actually trained peer leaders to do this as well. But what we found is there were only certain groups who actually had the time to make this commitment. The biggest piece of feedback we got is, oh, that's a lot. That's a big ask. So we retooled even more and we narrowed it down to 6 topics, including more recently moral distress, which was added based on feedback from medical residents and fellows. And we still offer this series. And as I'll show you, we've actually done more than 400 total workshops with our healthcare workers over the past few years, focused on these topics. But this was really the whittling down, the distilling was really based on feedback of nobody's got time for that. So we especially for residents and fellows who do have a little bit of time, we made the series shorter. But there's even a further adaptation I'll talk about in a few minutes. This is just showing that we've done well over 400 at this point workshops since we started. Very little. We started with very small in July 2020, piloting this. And the pink line is the cumulative workshop, so adding month over month. Okay. And we actually do try to capture some assessment data. It's hard to get pre-post psychological outcome data, especially as you're doing something live as a crisis is unfolding. But even very early on, we were able to ask people these 5 questions from Frascani scales that have been used at Sinai before to evaluate programs. We asked them, do you feel the workshops give you tools to do your job well, for outside life, increase your ability to bounce back, shows leadership value, and did you feel less stressed afterwards? We give these immediately after the workshop is over. And what we see, small font, is that in general, people really like these workshops. They found them to be impactful, even a single session. They found that it gave them tools to do their job well, tools for outside of work, inside of work, and it shows leadership value and that leadership engagement and sense that leadership cares about them and is like making time for them to do this. Is really, really important. So you can see in gray, if you combine that together, those are people that agree or strongly agree with those items, which is really striking again for a very brief single session intervention, a psychoeducational intervention. Okay, so we learned from this, and I alluded to this before, that well, first off, the needs changed. COVID-19, the acute phases ended, so we had to adapt the content, and we've been doing that, and added moral distress from the general practice of healthcare, not from COVID specifically. And there are further adaptations where we've reduced the time significantly. Okay, one of the other things that we've done, before I pivot to other adaptations, excuse me, is develop a Wellness Hub mobile app. So this is our mobile app for all of our staff at Mount Sinai. It is a confidential self-assessment platform, so confidential self-screening. Has the benefit of not asking someone to engage with a healthcare provider or to identify themselves. Staff can download this app and do screening tools and get feedback about what their mental health and well-being is. And they can do some of those same workshop topics in a self-guided way in the app. We're planning a clinical trial for it really soon, where we've jazzed it up a bit and put in a number of different engagement metrics. So we'll be able to see very carefully how people are using it. But right now we have over 1,400 folks that in the Mount Sinai Health System, employees that are using this at their own pace. Okay, so let me tell you a little bit about the HRSA grant and what that entails. So we were very lucky to get funding right through advocacy of the Warner Breen Foundation. There was about $100 million opened up for HRSA for healthcare worker well-being programs. And in January 2022, we learned that we got one of them. And really, it involves on our side in CSRPG, our center, on-site training about mental health and resilience. So not asking people to come to a 45-minute or 30-minute Zoom or in-person workshop, but to actually go to them. And this has been very, very fun and successful. It has also allowed us to do a number of different surveys, which I'll just allude to briefly. Okay, briefly, and you all know this, if you work in a health system, there's been a lot of new stressors, including verbal abuse, physical abuse in the workplace, and a lot of folks considering leaving healthcare and leaving their current job. This is particularly prevalent among nurses. These are the new stressors. And the predictors of leaving healthcare include workplace culture. And when we do our statistical analysis, workplace culture is a significant predictor, in addition to these other things. So that's sort of the new stress that we have to adapt our content to deal with. Okay, and this is a topic for a whole nother talk, it could be, but there's also a huge need for mental health services and barriers to care. And I should say that the barriers to care differ based on certain groups. So the credentialing concerns, for example, affecting your medical license and ability to practice, those wouldn't apply for support staff, for example. They might have more internal stigma, for example. But so we need to really look at how stigma and barriers to care differ among the different occupational groups that we serve. Okay, we talk about our approach of going to units to try to take down these barriers and to make access as easy as possible. And this work also applies to support staff. So this grant has allowed us to go into emergency departments, OB units, ICUs across the health system in our Mount Sinai Health System. And over the past about year or so, we've been able to reach 835 unique healthcare workers going to their 7 a.m. huddles and their 7 p.m. huddles with 13 5-minute topics. They're not pulled out for any length of time. We go to them, they're kind of a captive audience. And we talk about things like trust, team building, social support, psychological first aid, identifying signs of distress. And this has been a very good way of engaging staff. And in general, we see that the staff that we've engaged are largely female, and they're also largely non-white, which does match the demographic of New York City. And what I found, even personally doing this, is that when I ask staff, have you heard of our Center for Stress Resilience Personal Growth at the start of these huddles, nobody raises their hand. And no one might raise their hand because these nurses and other support staff on these units are not checking their email during the day. They're not looking at broadcast notifications that the hospital sends out. They get their email, they get their information through these operational huddles. So that's how we need to be telling them about things. We can't rely on electronic means that they might not even look at, or might get so many emails that it just gets overlooked. Okay, I'm going to skip over that for now. Again, also interestingly, the Huddle feedback, the same questions, mirrors the feedback we get from the longer form workshops, which means even a tiny dose has the same positive effect, at least on these 5 items, than a big dose, which is also kind of fascinating. Or a longer conversation, the short conversation and the long conversation have kind of the same outcomes. All right, let me talk about security officers in particular. So our particular outreach to security really, and I should say one of the biggest cornerstones of our community-based work is relationship building. So we have maybe 6 months of trust building needs assessment conversations with security staff and security leadership prior to doing anything interventional. All of these community-based efforts have to start with trust building conversations. Going to them, talking to them, seeing what their day is like, seeing what their needs are, building trust, building a sense of reliability, and buy-in to the interventions. So we're actually able to reach, ultimately, that 74% of all of the Mount Sinai Hospital security officers and almost all of security supervisors. And they all got a huddle, a 10-minute presentation on psychological first aid, how to support each other, how to engage in resources and support if you needed them. And we also offer a sort of outreach after workplace violence. So if a security officer has had an incident of workplace violence, we're available in our center to assertively, proactively reach out to them and check in. The security supervisors, because we know this leadership infrastructure is so important, the security officer supervisors got a separate training on psychological first aid. So how to respond when an officer has been hit. What do you notice? What are the signs of psychological stress? How do you respond to them in an authentic way? How do you support their basic needs and their emotional needs? Again, the point of psychological first aid is, to be blunt, to not be a therapist, but to be a human being. How to comfort them, how to say that they're being protected, and how to link them to resources. So these security supervisors get from us a specialized training in this, because we know that security officers in particular are at the front lines of workplace violence and have high turnover, in part probably because of that. And actually, we have a paper that's about to be published about these initial efforts of security. So be on the lookout for that. Okay, again, security officers, largely male, maybe not surprising given our understanding of law enforcement demographics. And also almost entirely people of color, almost entirely. I think it is 5%, it was 5% white, if I'm reading it. It's 1% actually white, if I'm reading this correctly. So really reaching out to the folks who, again, don't get communications by email and only get the information through their operational huddles and absolutely need it the most. So we have to go to them and adapt, come out of the ivory tower a little bit, and make the material very much speaking to their daily experience and meaningful to them. And again, actually, these are more positive. So kind of, if you build it, they will come. These security huddles, specifically for the officers, had the best outcome ratings in terms of the self-report feedback that we got afterwards. These are higher ratings than we saw in any of our other programs, maybe in part because this is one of the first programs that specifically outreaches to their emotional support needs. Okay, and just briefly, I'm going to touch on this just ever so slightly. We actually took some of this work with our internal community, our healthcare worker workshops and huddles, and through funding from the Robin Hood Foundation, adapted it and drew on about a decade of community health partnerships to teach faith leaders in the Bronx, Brooklyn, Harlem, to do the resilience workshops with their congregations. So we did a year-long project where over the course of, through 9 faith-based organizations, all in communities of color, 61 workshops were offered, reaching around 1,000 people, where the pastors, community health workers were trained by us for almost 6 hours, and then they in turn offered the workshops to their congregations, really at a very high time of need. And we recently published on that as well. Let me just talk to you briefly about another parallel effort I mentioned, spiritual care. So Center for Spirituality and Health is another center at Mount Sinai Health System that we work very closely with in our center. And the chaplains spend the majority of their time, about 60%, supporting patients and about 40% of their time supporting staff. So if you look at the breakdown of chaplain effort at Sinai, there's a huge amount of effort that chaplains put into supporting staff. They're visible on the units, they're reachable, they're imminently trusted, they're very kind, they're very skilled, they're excellent support, sources of emotional and spiritual support. And one of the things that was stood up about 5 or 6 years ago was what used to be called the Chi Time card, is now called the Take 10 card. And it's a ritualized tea service with snacks, with aromatherapy, with essential oils, with soft, calming music. You turn down the lighting. And there are snack bars, like little health snack bars. And this has been wildly popular. And chaplains go to units like the ICU, the EDs, ambulatory care practices, and offer these Take 10 experiences on a regular basis. And this is just an example of that, an illustration. We actually we sort of combined forces, and after units have done our HRSA huddles, we have now joined the Take 10 carts as psychologists and social workers to provide adjacent mental health interventions and increased mental health awareness. So chaplain is doing the Take 10 cart, for example, in the emergency department. And one of our psychologists is off to the side teaching about stress management or reinforcing the fact that the mental health resources exist within our center. So we're able to capitalize and supplement this really beloved resource within the health system. And every chaplain who does this, every support staff who does this intervention leads the intervention, does a red cap form. So we actually know about every one of these Take 10 experiences that have ever been offered, because there's data on when, where, who, how in a red cap database. And so we can do something cool like this, where, remember I said chaplains were doing a whole lot during the pandemic? This shows it. So the Take 10 cart visits to units actually were the highest ever. There were 493 Take 10 cart visits in the second quarter of 2020 when the pandemic was its absolute worst. So they were requested the most, and they showed up and did it virtually or in person. But that support effort ramped up because the units knew these chaplains and they were there at a very critical time. So I would say again, this important lesson for all staff, including support staff, is a trusting, consistent relationship is absolutely vital for any piece of programming that you deploy. If you don't have face recognition, trust, and reliability, and a plan for sustaining the intervention, then it's not going to be helpful. And there's just a huge number of staff served. The non-unique staff members served in 2022 were 25,000, and 147 different departments were visited with Take 10. So this is a very inexpensive, but very, very, very helpful intervention, and it has very positive impact ratings. Just like our programs, those same questions are very, very positive for Take 10. Again, a very brief mobile intervention, and each of the different Take 10 facilitators get trained extensively in how to deploy it. I'm going to just talk about our faculty practice, where we provide behavioral health care very briefly, in part because it intersects with our work to support security and support staff. So we, through the feedback from our Accelerator and through our community-based efforts, learned that the obvious maybe that a lot of staff don't have privacy during the workday. So if they wanted to get psychotherapy or medication management or on their lunch break or after work hours before they go home, they have no private place to do that. So as part of our treatment service that we have in our center, we actually built remote psychotherapy spaces. So they're telehealth rooms that a staff member, say an OR technician, can go to during the workday on campus to get a secure private visit with their provider in our center. We are in network for all of the insurances at Mount Sinai. I think this is often an access issue where some behavioral health services that are hospital-based either are EAPs and are 1 or 2 or 3 visits, or they only take certain insurances, and not all of the insurances that the employee workforce has, especially if there's union insurance. We made a decision very early on, with the support of our leadership in the health system, to take everyone's insurance. So the union-based insurances and the non-union employees' insurances. We provide cognitive behavioral therapy that is standard of care. And we can really see everyone, including adult covered spouses and dependents of Mount Sinai employees or trainees. We're behind a number of different privacy protections, but importantly, do document in the medical record and do bill out to insurance, so we can be relatively self-sustaining. I think one of the pitfalls of other behavioral health services, in an effort to protect privacy of the employees, they don't bill out to insurance, and yet then they don't have revenue to support themselves. So it's a delicate balance. we've done actually probably closer to 15,000 visits at this point since October 2020. We've discharged over 600 employees, many of whom do not need further care. And we connect people within 5 business days to an appointment. That's very good for behavioral health service. And it's also because employees work. They work they work during the day. So it can be a little bit of a juggling act trying to find appointments. But we see people on average also 14 visits. We try to keep the treatment relatively circumscribed so we can have turnover and throughput and see more people. If you have an indefinitely open-ended service, you really can fill up very quickly. Again, patient, generally non-white, largely female, very significantly skewed female, that does somewhat match our experience in prior studies of behavioral health service utilization, where women tend to, or those identifying as women tend to utilize more. But again, we do mirror the demographics of New York City. Here, important point, what I highlighted in bold is that our biggest utilizers, just sum total, are not nurses, physicians, advanced care providers. The top group that utilizes our administrative staff. So think about administrative assistants, program coordinators, back office staff, also medical assistants, security officers, a sort of a lesser group, but we really want to increase the actual utilization after the huddles of that group. But I want to point out that administrative staff, again, very few papers looking at their needs, were the group with the highest percentage utilization, or of all of the groups, those had the greatest representation among our treatment cohort. So these are the job categories of the patients that we see. And in general, I'll just show this baseline data that there is a pretty high representation of depression, anxiety, and even some suicidal ideation. 13% of the patients that we take care of who are our own employees present with thoughts of being better off dead, or thoughts of suicide, or thoughts of self-harm rather. So that's very concerning. And physicians in part have one of the highest national suicide rates. But what we do know is that our treatment works in that the scores on depression, anxiety, and suicidality drop dramatically over the course of 14 visits. And I think this shows that if you have an accessible service, you take people's insurance, you don't make them wait, and you do the standard of care, it pays off. And it is actually pretty sustainable if you set it up properly. But these are very dramatic drops. And as you know, if an employee or many people on a unit are struggling with depression and anxiety, they're probably not communicating as effectively. They're probably quite irritable. They might call out a lot. They might have presenteeism. And you would suppose, though we don't have data to show this, that treating those things makes the unit run better, makes patient care better, and makes people show up to work more. I want to play something. I think this should work. We recorded a brief video about what resilience means. And I think one of the things that strikes me most about this video is that the production team that we worked with went up to staff in the lobby of the hospital and asked, what does resilience mean to you? And this is actually on our school's YouTube page.
To me, resiliency is to keep moving forward, to endure and survive.
It means to help them to get over that particular bump or hurdle that they're getting through.
Toughness, being tenacious, and being determined.
Don't let nobody hold you down. Resiliency. Bounce back up and motivate yourself.
Even when the odds seem against you, just doing your best to overcome them.
So I think that support from community and family is a critical and often kind of under-recognized aspect of resilience.
It doesn't matter what the outcome is, just like working through that problem. That's what resilience means to me.
To me.
So in conclusion, with ample time to answer questions, our Q&A, leadership buy-in in our efforts has been essential. If the leaders on a unit don't know us, don't trust us, they won't open the doors and the programs won't be successful. Same true for staff buy-in. There is absolutely no universal approach. So there are many papers, and many of those on the call might have been involved in these papers of yoga, meditation for healthcare workers. But I think what really we need to think about is, what do particular subgroups of employees need? What can they actually do? Because they might need something pretty substantial, but they might not be able to in terms of their time, commit to something substantial. So we really need to think about the messaging there, what their particular stressors are, and you're not going to learn that unless you actually talk to them. So I think a lot of in the trenches conversations have been at the cornerstone really of what we've been doing. Physicians and nurses are not generally the highest utilizers of care. If we look at the data, and we're publishing on this as well, I think it's important to look at everybody else who works at the health system. You go on Google Scholar, how many papers do you see of PTSD and depression and anxiety rates, again, in nurses and doctors and PAs and nurse practitioners? And you have to really, trudge through the literature to find documentation of the needs of anybody else at all. At least I would argue. Engagement of security officers and other support staff. And we really need to do a lot of more assertive outreach to address access barriers. And the one thing I'll say here is that it's really hard to get data about some of these programs because we have brief, condensed contact, and people are very busy, right? When we go to the huddles, we're talking for 5 minutes, we're asking them to do an attendance survey, and then they have to go off and see their patients because we delayed them 5 or 10 minutes. So getting data on the psychological impact in terms of resilience or burnout has been challenging. I think our biggest impact is raising awareness that supports exist. I think, certainly topic for another talk, I think burnout interventions, as we think about them, have to be multi-level. In fact, there's actually an increasing number of federal government calls for proposals looking at burnout as a multi-level interventions that are at multiple levels, not just the individual doing meditation on their phone or yoga on their phone, but again, just like we do, engaging leadership and moving to shift structures a little bit.
To me.
Oops. Okay, so thank you very much for the time and the invitation to speak. We were funded and supported by NIOSH. I'm sorry, that's HRSA, not NIOSH. HRSA, NIH, Aronson, Robin Hood Foundation, Gottesman Foundation. And that's my contact information. And I'm happy to field emails to that email address and answer questions. Okay, I turn it over to Q&A.
Thank you so much for that excellent presentation. To everyone participating today, please put your questions in the Q&A box. And so I will go ahead and start us off while folks are formulating their questions. So I thought it was really interesting that you said that you spent 6 months building trust with the security workers before you did huddles with them. And I was wondering if you could describe a little bit more of what that trust building process was like. Was it really formal where you had meetings every couple of weeks? Like, how did that work?
Yeah, having Zoom meetings is really tough, especially with leaders, because they're very busy. So some of that was finding the time to actually go and meet them because they're so busy doing the stressful work that they do. But I think our chaplaincy relationships, so our Director of Community Engagement, Dr. Dana Costello, is an expert in building relationships and has many trusting relationships with security. And this involved actually going to their operational huddles, speaking to managers, but actually going to meet staff, building face recognition. I think one of the things that I want to emphasize is in a big hospital system, especially in units like the ICU or ED, while they are first on the scene to respond, how often is it that we actually know the names, even very basically, of our security staff or our EVS staff? And that is a first essential component. Know the folks. Say hello. When you walk into the hospital in the morning, say hello to the security behind the desk. If you sit and observe, that never happens. Like maybe 1 in 100 people will say hello, but start there. That's very basic.
Thank you. Okay, so we have some questions rolling in. So this one is, how would you define the difference between resiliency and burnout, both conceptually as well as how the constructs are operationalized?
Oh my goodness, tough psychologist question. Okay, so 2 things. One, definitionally, I define burnout as this ability or capacity to grow, adapt, recover from challenges. And burnout is often defined as like cynicism, disconnection from the fruits of our work, feeling like it's not meaningful anymore, and being emotionally withdrawn or shut down. And what we do know is that they are not necessarily strongly correlated. So that is not that's to say that you will not find a particularly robust correlation and negative correlation between burnout on the one side and resilience on the other, because, and maybe it's a measurement problem, but healthcare workers are pretty darn resilient. They have to adapt to change on a moment-to-moment basis. They have a lot of challenges thrown after them. They're pretty gritty, and they're in an exhausting, very challenging environment. I think everybody's coping capacities have their limits, but I think that the folks that we see in the health system are very resilient and also at the same time tired.
Thank you. Okay, so next question is, what are some best approaches and successes to get leadership buy-in?
Start at places where you already have relationships, demonstrate success, and measure things. Leaders really like, I would speak to the leaders at our health system. They really like numbers. So the data, for example, that I showed about our treatment outcomes, we measure treatment outcomes and we can plot them and show them. So have data behind, have evidence behind your rationale, have a sense of what the need is, and measure outcomes so you can demonstrate in a small scale kind of way to leaders when you're going someplace else that this worked and it had at least emotional return on investment. Should show its value is, I think, the most important thing. And ideally, it wouldn't be that expensive because none of our things are expensive.
Okay, great. Okay, so this next question, I think, is referring back to some of your data slides. A little confusion about what you mean about unique and non-unique staff.
Oh, yeah. So unique staff are a specific individual. So 800 unique nurses. So Jane Doe number one, John Doe number one, have come to our HRSA interventions, and non-unique is repeat customers. So unique participants is that unique individual. So we've reached 800 so unique individuals, and it was, I think, 1,200, 1,400 something people total. So that can mean that one person attends on average 2 or 3 times.
Okay, great. So this next question is asking about the difference between burnout and moral injury.
Oh yeah, so if you know, there's a physician on YouTube who's very active who says that burnout is essentially moral injury. So moral injury, and it gets into the nuance. There's moral distress and moral injury. Moral distress, which is probably more common, is having a distress that results from not being able to do what you think is the right thing to do in a situation, given individual or structural barriers. Moral injury is typically defined as actively participating in, or the distress that results from actively participating in or failing to prevent harm. And this was, moral injury was identified initially in combat veterans. So think about Vietnam veterans involved in the killing of civilians, evoking moral injury. So I think that certainly moral injury can be one of the experiences that contribute to a sense of burnout, you know, broadly speaking, a sense of, say, exhaustion, right? If you're working in an environment where you have the perception that you're being asked to do things that you think are wrong, or you can't do what you think is a standard of care for a variety of reasons, that's exhausting and makes you withdraw potentially from your work. But as you know, also exhausting things are a medical record system that's really clunky and hard to use, and a lot of documentation that takes you away from patient care. A lot of things like prior authorizations that providers have to deal with that take them away from patient care. Because if you think about, especially for our providers, they want to be sitting and talking to patients. Anything that takes them away from sitting and talking to patients is distressing. potentially, and is not value added for them.
Mhm.
So I think I would say moral injury and moral distressing situations can contribute to burnout, but as can a whole bunch of institutional red tape.
Okay, thank you. So the next question is, how is resiliency related to fatigue, related to shifts in specific job demands in healthcare?
Oh my goodness. I'd say that I'll give you an example for myself. When do I feel most functioning at my best? So I feel functioning at my best when things are going well at work and I don't have 100 emails to deal with after my workday ends, or maybe I have like half the usual amount of Zoom meetings. All that to say that if I'm not functioning at my best, the things that I do and the resources that I lean on are different than those that on days that I'm functioning at my best. So I think one of the disadvantages of a one-size-fits-all approach that says yoga for everybody and mindfulness for everyone is that it may not be mindful of or pay respect to that might work for somebody on a really good day, but not on a bad day. On a bad day, what do? I eat ice cream on my couch and text with my friends and commiserate. But on a good day, I might actually get on my exercise bike and have it not collect dust.
So next question, you mentioned a 6-hour virtual training module that was provided to community health advisors. Is that training available?
Yeah, so that's something you could certainly email me about. So definitely reach out to me by email. This is called the Building Community Resilience Program. We published in Journal of Community Health, actually January of this year. And our follow-up adaptation of security officers should also hopefully be published in the next few weeks.
What were the factors that increased the participation of African or Black American, which was 27%, and Asian, which was 25% in an earlier pie chart? This is unusual. Is the workforce reflective of these percentages?
Yeah, so it's a very good question. What I would say is, it also partly reflects the demographics of the occupational groups that we were initially targeting with some of these workshops. So in some of our initial workshops, our first partnered group was physicians assistants. And the demographic makeup of that physician assistant group was, and that profession is likely different than the demographic makeup in terms of race, ethnicity, and identifications of, say, security officers or EVS. It may skew more white identifying or Caucasian. So some of those numbers are not necessary, or maybe more reflective of the groups that we initially targeted than differential participation of different individuals of different races or ethnicities within those very groups, if that makes sense.
So another question is about if you have any theories about why administrative staff are the largest percentage of patients for the mental health support and treatment that you offer.
Yeah, well, first off, there's a lot of them. In a health system, there's a lot of people who are not nurses or doctors that make the institution run. There's a lot of office staff. We have a huge ambulatory practice footprint. And I think that historically, more work needed to be done to encourage those folks that the resources available in our health system to support their mental health are specifically for them and not just for nurses and doctors. Because nurses and doctors get all of the journal articles and attention and those kinds of things about their mental health needs. And they face unique stressors. They might be more likely to be members of historically disadvantaged groups. They might have had more historical access problems to services, but there are also stressors like huge workloads. I've observed patients in ambulatory care practices where I'm waiting to be seen as well be very, very rude to front desk staff because they are anxious about a test result or wanting to be seen right away. So those folks that work in these places do face and are the first person that a patient sees when they come into a service sometimes. So they're like sometimes the first line of defense or the first person to hear the frustration, and they might not feel like there's any forum for them to debrief.
Okay, so I think our last question will be the perfect wrap up. So what's next for your research?
Oh, so we are going to be doing a internal clinical trial with our healthcare workers with our Wellness Hub app to see how engagement with 5 or 6 different modules of resilience and mental health related content, psychoeducational content with take-home exercises, builds resilience and improves psychological well-being. We are also going to be publishing more on our treatment data. Hopefully there's a first paper about our treatment outcomes that will be in press soon. And we're really thinking about expanding it, and we have private foundation funding to expand some of our work of security to security officers at other hospitals in our health system and to other members of support staff. So we're going to be quite busy. And there's also a number of different large-scale workforce surveys that we're doing about mental health and well-being. And as I said, there's been about 20 or so publications so far from those surveys. We just did one last August. We're kind of mining that for useful publication. And we're about to do one next year with faculty and staff as well, where there's going to be a number of publications that come out of that, particularly I'm interested in barriers to care and service utilization and what we can do to shift the needle on people who say they need care, actually using the care that's available to them, specifically at Mount Sinai.
Well, thank you all for joining us today for this excellent presentation. And with that, we're just about out of time. A big thank you to Dr. DePierro and to everyone who joined us today. We invite you to stay connected with us through our website and social media and to sign up for the Total Worker Health in Action newsletter to stay up to date on the latest news from our program and partners. Thank you all so very much and enjoy the rest of your day. Thank you all.